faculty were learning how to do laparoscopic cholecystectomy, the stakes were high. No one wanted to injure a common bile duct, and they remain high to this day. However, this operation now has become the standard. Everybody's doing it. It's a great operation. Now, can we say the same thing about the spectrum of hernia surgery? When can we start a new procedure? How long do we need to follow the patients to say that this operation is good? That's why we have experts in this room today to tell us, how do we need to evaluate the literature? What is the evidence? How do we need to proceed with new technology, new operations? So for the first talk on how to achieve best evidence, we have Dr. Sabrina Drexel from the Northwest Hernia Center in Portland, Oregon. Sabrina.
Thank you so much for the opportunity to talk about how to achieve best evidence. These are my disclosures, none of which are relevant to this talk. I do want to disclose that I'm not a basic science researcher, and I'm really just trying to strive to practice evidence-based medicine every day in my clinical practice and private practice. So hopefully I bring a unique perspective. When I first started thinking about this talk, I really asked myself, how do we define evidence? And the definition of evidence has really evolved over the last 80 years or so. So I wanted to start with this quick historical vignette about the development of the lobotomy. In the 1930s, a Portugal neurologist, Dr. Igas Moniz, developed the technique for the lobotomy. And despite very little clinical outcome evidence, it was propagated throughout the world. And he actually won the Nobel Prize for this invention in 1949. And you have to remember, they were operating at a time when there was no pharmacotherapy for patients. And really the philosophy among physicians was it's better to do something than nothing. In the United States, it was championed by Walter Freeman, who did about 5,000 lobotomies on his own, and over 50,000 were done in the United States until it was finally banned in 1970 with the advent of pharmacotherapy to treat psychological illnesses. And he did actually collect a lot of evidence in his day, and it was through photography. And so this was one of the many cases he took pictures of over the years of a patient pre-lobotomy in the kind of left corner there. And she's, frowning a little bit, looks a little bit sad. And then after lobotomy is kind of joyful and smiling in the photos. And these were accepted to prominent medical journals as scientific proof for the lobotomy as a medically acceptable treatment for psychological illness. Now, I think many of us would doubt using photography alone for proving a invasive technique. But you have to put this into historical context. And there was a large precedent set in psychotherapy and neurology about the face as a window into the soul. And so this was actually well accepted. So I think we've come a long way from accepting photography as medical evidence. And we're kind of in the day and age of statistics. And Dr. Miriam Posner is a professor in informational studies and digital humanities at UCLA. And I think she puts, the question to us quite poignantly when she says, we find ourselves now in a time where data and statistics claim an enormous amount of cultural authority. But one of the central questions remains is, what can statistics capture and what kind of meaning eludes these methods? So I want to bring up another modern tale with the evolution of inguinal hernia repairs. And I think we're all familiar with the rival trial and its data, not showing superiority of the robotic techniques for inguinal hernia compared to laparoscopy when we look at patient outcomes and surgeon ergonomics. And I think many of us would say, what are these statistics not capturing? And I don't bring up this study to be inflammatory in any means, but really just can statistics alone answer this question of the difference between robotics and laparoscopy? And my answer to that question right now, at least, would probably be no. So how are we trying to achieve our best evidence? The rival trial is kind of at the top of primary research in terms of a prospective randomized controlled trial. And then we certainly have, meta-analysis and systematic reviews kind of at the top of our evidence pyramid. But when we put this in the greater context of spheres of evidence, our primary and original studies are still at kind of the bottom of this pyramid. And even our meta-analysis kind of only step up to the next level. And really what we're trying to strive for is, practice guidelines and really broad-based evidence that we can and apply to our everyday practices for people like myself, especially in private practice. But that's been especially challenging in the hernia world to achieve those because of the lack of high-level data to make broad statements in regards to many different practice guidelines for hernia research specifically. The top of the pyramid and kind of system-based evidence is really kind of the future, hopefully, of medical evidence and really only exists in medical oncology fields, such as clinical trials for certain medications in medical oncology. So kind of what are the challenges in the hernia field specifically? I think I've heard heterogeneity come up many times in the debates we just had in the last session of heterogeneity of the patients, of the hernia itself, of the technique to fix the defect, of the type of implant you use, and the skill set of the surgeon available. And those are very hard variables to control for, which is why we don't have high-level randomized controlled trials in hernia research, and we often resort to case control and retrospective reviews. I think new techniques, it's been amazing to see, surgeons around the world operating and sharing their techniques and tips through social media platforms, but we are often adopting those without any basis of evidence for those. So we do need to have, a cautious approach when we are rapidly sharing new techniques among each other. I think, reproducibility, similarly, a different surgeon in a different area of the world may have different access to, laparoscopy and robotics and different mesh or implant products. And so it can be hard to translate evidence from one study into your practice and what you have available to you. And finally, again, we don't have high levels of evidence to make these practice guidelines. I think we all wish we could. For example, I worked on the mesh plug advisory for the practice advisory committee with AHS, and we weren't able to strongly say against putting in mesh plugs because we simply don't have the evidence yet to be able to say that, despite many of us believing that are here today. So how do we get there? I think the first thing is we all need to start using the same language. The Europeans have come up with this great classification systems for both inguinals and ventral hernias. I think many surgeons around the world use these, and I think in the US, we're actually way behind in using these. I think you quiz most general surgeons in the United States and they would not know this algorithm of how to classify ventral and inguinal hernias. And I think the people here are probably the only people using these. So trying to adopt a more universal language so that we know we're speaking the same language among different types of hernias. And that also goes to the type of technique. We've had colleagues publish on this kind of alphabet soup that Dr. Nowitzki referenced earlier today about, the many, many different techniques, but ensuring that we're standardizing those techniques and all speaking that we're using the same technique when we use these acronyms. And then I think a step further of figuring out how do we standardize how we talk about mesh. And, this has been proposed by Dr. Blatnick and colleagues of kind of a nutrition label for mesh products because, data on a mesh from 15 years ago probably isn't applicable to that mesh today because it's probably evolved and changed in the way it's been designed, yet we don't really know that because we don't have access to information about the mesh well enough. Moving on to kind of data collection. This is a systematic review of outcomes reporting in incisional hernia repairs. It was 92 studies and 12,000 patients, and not 100% of these studies even reported recurrence rates, which most of us think as our primary endpoint when we think about hernia data. And they had 9 different definitions of what a recurrence was. And only 1/3 of the studies included patient-reported outcomes, and they used 18 different assessment tools. And so this systematic review looked at kind of the outcomes. There was 8 broad categories of outcomes that you could be defined, but you can see numerous variables. And this makes it really challenging to come up with, systematic reviews and meta-analysis and the kind of those higher secondary levels of studies when we can't figure out these definitions among ourselves. In terms of data collection using databases, I think is becoming more and more prominent, but definitely needs to be more so in the United States. And so Dr. Moisens developed the EURA-HS system, which kind of got incorporated into the EHS registry, which again uses those EHS definitions of hernias so that they can compare, the same hernia to the same hernia, which we don't we're getting there on this level of evidence in the United States. And they, in this paper, really nicely discussed, probably all the variables we care about between patients, the procedure itself, and the prosthesis. We should kind of be collecting that information on every patient so that we can study our outcomes in a meaningful way. I think the other part of data collection is we need to look at our oncology colleagues who now have this mandate from the American College of Surgery about synoptic op reports. And the goal is really to ensure that quality oncologic resections are being done by oncologists in many different surgical fields, from breast to thyroid to colorectal, but it standardizes their op reports. I think we've all had that experience when you get a patient referral for a recurrence or a second some type of chronic pain, and you do your due diligence, you go get that op report, you read it, and you have no idea what the surgeon actually did. And so I think trying to standardize in some way so that we are all speaking the same language in our documentation would help elevate our level of evidence. This is what I do in my operative report, so certainly not the only way to create some type of hernia synoptic report. I selfishly do this for my coders with our new 2023 codes in the United States. I make it easy for them to find the size of the defect and whether or not it was incarcerated. Certainly this could be changed, but just one idea of putting this at the top of every single operative note makes it very simple for any other surgeon that's seeing that patient for any reason to know what was done, where was the mesh placed, what type of mesh was used. Moving on to study design. In the 1990s, there was some criticism among journal researchers about kind of the lack of appropriate medical evidence. And Doug Altman wrote that we need less research, better research, and research done for the right reasons. And Richard Horton went on to say about surgical research specifically, you know, is it actual research or kind of a comic opera? And he really just commented that the personal attributes that go to make a successful surgeon differ from those needed for collaborative multi-center research. And so, you know, ensuring that you have a statistician that's doing appropriate study design is critical to ensure that our studies are at a high level of evidence. The Precise2 algorithm is a tool online that you can use to really help guide what is the aim of your clinical trial, and is really trying to ask, you know, are you aiming to take an exploratory approach, explanatory approach of can this intervention work under ideal conditions versus a more pragmatic approach of does this intervention work under usual conditions? And many of us are trying to answer those more pragmatic questions in hernia research, but unfortunately they don't get answered by the time a study is designed. So they have this kind of 9-wheel spokes of different categories to help you really figure out where does your study fall, and do you need to change some of the ways that your study is designed to hopefully answer the question that you're really trying to. I think that's echoed in this paper from our colleagues from 2012 about reporting outcomes, results in abdominal wall hernia repairs, and that it's of utmost importance to know how the study population was decided upon, how the study was conducted, what the primary aim or endpoint of the study was, and how the endpoint was analyzed. Now, that seems pretty basic for anyone thinking about a research paper, but the vast majority of studies in hernia care actually don't include all of these elements, which is why this paper was important to really describe those. And they went on to go to categorize every different type of study you can do. There actually is, you know, an online standardization to ensure that your study is built with sound methodological systems, and to ensure that, you know, the statistics you're running are actually appropriate. So you can find, based on the type of study that you're designing, you know, appropriate standards to follow. And then finally, it's kind of hard to talk about evidence without commenting on, you know, the immense amount of collaboration we've had over the last 3 decades, and that will continue to advance our field in hernia surgery. And once again, we look to our European colleagues in the Danish and Swedish databases specifically that have you know, that are publicly funded entities, in the Danish database that has, you know, mandated reporting, so that essentially almost every hernia patient in those countries are being tracked in a hernia database, and they can really make impactful studies about outcomes. Certainly, we're working with the ACHQC to expand our database here in the United States. We have surgeons in almost every state using it at this point, but it's still only about 2 to 3% of the general surgeons overall are participating. And so I think we have a lot of progress and a lot of potential growth and potential through the ACHQC. Finally, I'm excited about future evidence about what artificial intelligence means for us in achieving evidence within the hernia sphere, and what, you know, potentially some type of integrated EMR could do for truly tracking outcomes in the United States. And I'll leave you with this quote from John Tukey, who was a mathematician and statistician at the end of the 20th century, that the combination of some data and an aching desire for an answer does not ensure that a reasonable answer can be extracted from a given body of data. Thank you very much. I really look forward to our discussion.
I think, Dr. Drexel, we can take a couple of questions quickly from the audience. Any questions? Yeah.
Martin.
You can talk loudly. I can hear you.
Yeah. No, it's working now. Yeah, Martin Simmons from Amsterdam. Nice talk. The guidelines for incisional hernia actually were published yesterday, so that's breaking news in the British Journal. And statement, a good practice statement for follow-up of patients is not advice to be recurrence anymore and infection, etc., but quality of life.
Yeah.
So that's, you know, it's a new aspect which gives new challenges, but in the time of shared decision making and talking with the patient, what's important for the patient and all the different techniques, then maybe we should just only focus on their quality of life and not anymore on the recurrence rates, which are very difficult to measure.
I totally agree with you. And I think our understanding that a hernia repair should last a lifetime probably needs to be changed, because most knee replacements last a decade, et cetera. So that thought is great to really focus on the patient outcomes rather than recurrence rates.
It's a beautiful set of slides. It really is. And it's interesting that, you know, even the consideration of, and I love the point that you made about the difference between effectiveness, efficiency, and effectiveness of studies. Like what happens on the ground compared to you eliminate all the smokers, obese, pregnant people. I mean, and then like what happens in the emergency room is, it makes it totally different. And also too, I think that even if you do a really good study, one of the problems is what do you take out of it? What do you read from it? And what do you remember? And what do you digest? And how do you implement it? And until we actually make really good data and then make it actionable, it's hard for us to impact something, even the most common operations performed in the world, which are hernia repairs. And I think too, like in the common example, you mentioned like the brain. You know, people say we only use 10% of our brain. Do you know where that came from? It actually came from the study where, you know, it's very difficult to study the brain. And like, you have to have individual injuries and stuff to say, well, this, what makes your right arm move and your left arm move and your memory and that sort of thing. And what the study actually said was, we only know about 10% of what your brain actually does. And that translated to, we only use 10% of our brain. And that's what everybody talks about. And that's what the original study is. But beautiful set of slides. Any other questions? Hopefully we'll have a little chat at the end of this as well. Thank you very much. Next will be Neil Smart. That's a beautiful talk. So Neil Smart's coming up. I love Neil's perspective in coming from, one, he's believable because he has a UK accent. And then secondly, you know, Neil is it's incredibly well read, and being a journal editor certainly adds to that perspective. And so Neil, we look forward to your comments.
Thank you very much for the kind invitation to speak to you today. So we're going to start where we left off, these two seminal editorials from the 1990s, Doug Altman's in the BMJ in 94 and Richard Horton's in the Lancet in 1996. And those really important statements from Doug Altman, who was the professor of medical statistics in Oxford, who said, we need less research, better research, and research done for the right reasons. And of course, Horton, in that excoriating editorial about surgeons and their comic opera of research, said some critics might not even regard case series as research at all, rating unplanned observations as hopelessly invalid. It's fairly damning, and that pretty much wipes out about 90% of the hernia literature. And what we ended up with in the 1990s was a situation where we had some surgeons who were academics, and they were ensconced in ivory towers, often doing hardcore cellular and molecular work, which was disconnected from the everyday patient population. And it was often, if they were going to write about anything, it were niche operations for rare conditions and very small numbers. Whereas what we actually had was a mass of surgeons, a large collective, larger number, who had to deal with everyday problems for common conditions, which consume huge resources in whichever healthcare system you work in, and they just weren't getting studied. So 10 years later, were things any better? Well, no, sadly not. John Ioannidis from Stanford wrote this brilliant paper in PLOS Medicine, who said, actually, most of research that is published within the medical field is actually wrong, and largely because doctors aren't very good at statistics. We're pretty much innumerate when it comes to that. So the old Waldorf and Statler comment of it wasn't half bad, no, it was all bad, was still there. Did it get any better a decade later? Sadly not. I mean, this is a cracking paper from Steve Chapman. If you haven't had the opportunity to read it, I implore you all to go and have a look. It's from 2014 in the British Medical Journal. And Steve wrote this when he was an intern, postgraduate year one with 2 medical students. So if some of you are thinking about where do we start, how do I get going with research, you can start early and you can achieve big if you really want to and you set your mind to it. But they looked at all of the trials that were on clinical trials registries and looked at those that weren't publishing. And most of them had significant design flaws. And the key thing that kept coming out time and time again about why some of these trials never saw the light of day was industry funding tended to be the common reason why they weren't getting published. So what changed? Why did we get from somewhere so bad to somewhere good and where we can start implementing evidence? Well, the first thing that changed was infrastructure, and we have to give credit to Canada because they implemented the Canadian Institute of Health Research. And I think most of the things that I've put on the screen have relied heavily on the infrastructure ideas that the Canadians implemented. And certainly in the United Kingdom, we copied it, but funded it perhaps slightly better. We also started seeing changes in what were deemed to be training for our junior doctors and also the core competencies they were expected to have. And I've put up a pathway slide for what happens in the UK for academic training, but realistically, this could be done in many other places around the world. But the competencies on the screen, which come from the General Medical Council that I have to adhere to, are again copied almost verbatim from the Canadians, from their CAMMEDS framework, and saying that your ability to do and understand research is a core competency. And this has now been written into frameworks since the late 90s, early noughties. So we've got a new generation of doctors who've come through who understand research better for the first time. So how's that changed things? How have we got stuff from being in the publications into everyday practice? Well, the magic storm happened, didn't it? COVID came along and it hit us at a time when we were primed. We had the infrastructure, we had the people who knew what they were doing, and we could now ask big questions. And we could ask big questions that mattered to us as surgeons, to patients, to governments, to funders. Like, how do we do surgery safely in the middle of the worst pandemic in living memory? Collaboration was the key. The COVID Surge Collaborative came along and they answered those questions. 111 countries, nearly 1,500 different institutions contributed data on 200,000 patients from all around the world, pooling expertise, resources, data to get answers. How did that translate into meaningful practice? There was more than 10 papers in Lancet Group journals, 5 in the BMJ or similar, 20 in upper quartile surgical or anesthetic journals, highest ever cited paper in the British Journal of Surgery, numerous World Health Organization and government guidelines. And one of the key factors for achieving this was using single corporate authorship models to make sure everyone felt involved, engaged, and rewarded. You think, well, that's fairly generalist. How does that apply to hernia? Well, it applies directly to hernia because you can use exactly the same methodologies again, and they have done this year. The HIPPO study has been active from January through to May of this year. 18,000 patients prospectively collected, over 600 centers, 83 countries. And I'm very grateful for Neil Bangui for giving me this data to share with you today. Not in print yet, but will be by later this year. What we've seen is that globally, hernia is a major problem. Inguinal hernia is probably the biggest public health problem in surgery. And in low-income countries, patients have high rates of strangulation, high rates of emergency repair, high rates of bowel resection. We know that if we could implement local anesthetic, open day case mesh repair surgery for inguinal hernia, in low-income countries, we would have a dramatic impact on the health of millions of patients. So is that happening? Well, yes, it is. And they've taken those findings and started to implement them into randomized controlled trial study designs. We know that access to safe surgery is a really important factor for the World Health Organization, Lancet Commission on Global Surgery. And we know that many of you in the room will have done things like Hernia International or various other humanitarian surgeries. But if you put public and patients at the heart of it and ask them what's important to them, accessing that surgery is really crucial. And you can do that public and patient engagement. And it's led here by Stephen Tabiri, who many of you will know is the president of the Ghanaian Hernia Society. And they've designed the cluster randomized controlled trial, taking it forward, fully funded by NIHR in the UK, starting later this year. So what have we found? We found that if we've got an adequately trained workforce, we can do studies that answer bigger questions, more important questions, and better questions, and which are directly applicable to our practice as surgeons. And it works globally. If we have better trial methodology, we get better studies. And you cannot do this alone. You might think that you as a surgeon can do all of this. We can't. You do need other people to come and help you. It's a team sport. I encourage you, if you want to go fast, go alone. But if you want to go far, go together. And we know these things work for health generally. We've lived through this over the past 3 years with COVID, and we saw that you can do really clever trial designs like multi-arm, multi-stage rapidly and quickly. We did it for COVID, all the recovery trials with all these papers that were published in New England Journal, Lancet Group, etc. But you know what's really exciting? It's not just the physicians who can come along and do it with their fancy pills. We can do it in surgery too. And we are doing now. The Rossini 2 trial looking at surgical site infection, big question, matters to surgeons, matters to patients, matters to healthcare systems and funders. It's actually recruited over 6,000 patients now, and that's across United Kingdom and Australia. And you do multi-arm, multi-stage, where you have short-term outcomes, usually at 30 days for complications like SSI or SSO. And what you can do is the interventions that don't work, you drop off. I can tell you now, up front, that Ioban impregnated dressings don't reduce surgical site infection. Collagen impregnated sponges don't reduce surgical site infection, not for abdominal surgery. But innovation takes time, and we're all familiar with this S-shaped curve. We've seen it before for techniques, devices, whatever. And the length of that curve can be what? Anywhere between 10, 15, 20 years, something like that. Most of us are somewhere in the middle, but there are always people who are keen to be early adopters, and there are always going to be laggards. But how does that relate to hernia surgery? How do we get that innovation and that evidence into practice? How do we make it impactful? Well, I'm going to show you some challenges that we have. So many of you will be familiar with the STITCH trial, published in the Lancet, done from our colleagues in the Netherlands. And yes, I know that many of you will have criticisms about the methodology. But here's the rub. This is what's really interesting. It's been out there for quite some time. But what happens with implementation? Well, on the left is the paper that was looked at in Barcelona and Catalonia, and it's done by two really important people. One is Manuel Lopez Cano, who many of you will know, but the other person who's the second to last author is Miguel Pera, who is going to be the president-elect of the European Society of Coloproctology, two really preeminent surgeons in their field. And yet within their institutions, we can still only get 30% of patients having their primary incisions closed with small bite closure. And in the United Kingdom, prospective observational study, CIPHER, which I led, 2,500 patients, and only 40% of patients who had a midline incision had it closed by small bite closure. So it's really slow to take hold. Parastomal hernias, again, prophylactic mesh use, lots of evidence available. European Society of Guidelines recommends its use, but when you survey surgeons in Europe, do you use it? No, they don't. You do the same in North America, do you use it? No, they don't. And then we can ask further questions about what happens when you've got really good evidence for things like prophylaxis. So the ROCKS trial was published in the Lancet in 2020, just before COVID hit. Really well designed trial, 800 or so patients randomized to prophylactic biologic mesh at the time of stoma closure. You know what? It works. There's really good quality evidence for biologic mesh. And I know a lot of people have poo-pooed it, me included, and the way it's been used in some concepts, but here it works. But what happens? I run the training day for the Association of Coloproctology in the United Kingdom. This is the same group of surgeons who contributed and randomized patients to ROCKS. 100 UK colorectal surgeons. Who's placing prophylactic mesh when you close an ileostomy? No one. No one can tell me why, but there have been some people who've looked at it. So if you look at John Fisher's work, he's highlighted that surgeons are often the barrier. It's often the attitudes that they have, and they just say, well, I don't think it applies to me, or I know the evidence, but I'm worried about that. Well, if you knew the evidence, you knew that what you were worried about isn't the case. Difficult. So can evidence synthesis help us? Well, it can do if it's done well, but a lot of the time what we have is garbage in, garbage out, unfortunately. And we have a lot of people who don't follow the appropriate protocols. You know, there are really good standardized ways of reporting and conducting systematic reviews and meta-analyses, and they're all open access. But yet I spend most of my time hitting the reject button at the stuff that I get submitted to me because most of it's terrible and it's really badly done. What about guidelines? Can they help? Well, there are some things that are out there which are helpful and useful, but are there challenges? Well, there are, because we see things like this from EHS last year and AHS. But the problem is there are conflicts of interest which are not just financial, they're intellectual. And for the recommendation before, the people who did the primary studies were actually the people who were tasked with doing that key question in the guideline. And that's not what should happen according to GRADE and Agree-S. And yes, Martin, thank you for raising the point that the latest guidelines are out there. It's good, but there are still challenges with it. There aren't complete engagement of all stakeholder groups, and there's only one patient discussed in the actual paper for giving their views, and we should probably have better patient engagement for guideline. I implore you all to get up to speed with learning about guidelines and do the in-guide training. So in summary, where we're getting to, getting evidence into practice. Well, I hope I've managed to show you that academic surgery isn't just for the ivory tower, it's for everyone. It's more collaborative and accessible than ever before, and it's there for benefiting all of our patients. And if we revisit the seminal editorials, I'd like to say, do we have less research? I don't think so. We've still got a load of stuff which is terrible, but we have got better research. I think we've got research now which is done for the right reasons. It's better in terms of the collaboration, it's got better in terms of pragmatic trial design, and certainly the quality of publications has increased. Thank you very much for your attention.
Any questions from the audience? Sabrina, Neil talked about like the implementation of evidence, and you've trained at great programs, and then now you're in private practice and back near your home in the Northeast, or Northwest. So how do you go from your private practice? What do you read to implementation? What do you say? What impacts you to do something different?
Honestly, I ask my residents what other people are doing a lot. But it's a wealth of knowledge and resource, and they have a different perspective. And one of the things I love about my group is that we're always in each other's operating rooms. And so we get to see how people do things, which is not always the case at institutions. And then I stay involved. I mean, that's why I'm here. That's why I feel like it's important that even though I'm not at an academic institution, does not mean I can't be academic. And I want for my patients to have the best evidence being implemented for them. And that's honestly why I'm here.
Todd, I had a quick question. Neil, you know who I am. The levels of evidence that we have, that you have to know those. So 1A, 1B, etc. I think they need to be rewritten in terms of weighting, because those of us that have undertaken randomized controlled trials know how difficult it is. Patients don't listen, and we really need to change the way we create the levels of evidence and weight them, because you've got some poor randomized controlled trials. But then when you get a medical expert who's helping someone try to sue you, they'll say, look, I've got a level 1B evidence here, randomized controlled trial. What he did was wrong or not as good as what this should have been. So how would you tackle that?
Yeah, I couldn't agree with you more. I think those levels of evidence served a very useful purpose back in the 90s when we were starting that journey of evidence-based medicine. I don't think they're fit for purpose now. And certainly as we've got large data sets and the clever things that we can do with them, like instrumental variable analyses, and we'll probably should be doing more of that and less of things like propensity score matching, I think that there are going to be better ways of defining what we should be accepting as high quality. And I agree with you, there are many randomized controlled trials that probably should not have been done and should never have seen the light of day, and most of them are planned so poorly with no patient engagement. I don't think any credence should be given to them.
Hi, I'm Adil Cabral from Miami. one of the biggest issue that we face in this country and other places that I think COVID helped a little bit in breaking those barriers is data, how to get data. If you look at people who run insurance companies, it's all about claims data. But you have churning of patients, patients move, patients change insurances, and all this data is siloed in so many different areas. And it's impossible to track down. And if you had a common, almost a set of population data that it's almost when they talk about AI now, how research should be done, where literally those patients at every event in their life goes to a central data, then extraction and studies could be done in a way that would reflect the masses.
Yeah, and I think that's very true. And I think it's difficult when you come from Europe because many of our healthcare systems have just that. I mean, there's a unique registration number every Danish citizen has, and you can track them everywhere. I can do the same within the NHS, and all the patients who are in my research studies, I can follow them anywhere in England that they present. I can track them everywhere. It does make life easier, but there are ways around it, and the ways in which you can get around it is to do what our colleagues, the physicians, have done, and what particularly in IBD research, they empower the patient. And they say to the patient, you're the person who registers yourself, and they can now do it through a variety of apps, which again are aligned to things like REDCap databases, and the patient is empowered and they will put their data in. So wherever they go in the country, the patient will tell you what's happened to them. They will tell you their test results, and it works brilliantly. It's very powerful in IBD.
Neil, thank you for a very enlightening talk. The next speaker on new procedures and technologies, where is the evidence, is Dr. Yuritsa Perez Soto. Dr. Perez Soto is from the Physician Regional Medical Group in Naples, Florida.
Thank you to the AHS for the opportunity to present. I am from Naples, Florida. I practice in a for-profit hospital system. I am not an academic surgeon at all, so I'm going to do my best to present you what I think about where is the evidence for new procedures and technologies. These are my disclosures. I am a consultant for TelaBio and a proctor for Intuitive. I ask AI to render an image of what it thinks an abdominal wall reconstruction surgery looks like, and I think it's pretty neat. So new procedures and technologies. Knowledge about limitations of your data collection process affects what inferences you can draw from the data. This is from Nick Bostrom, which is a modern day philosopher. He is the founder of the Future of Humanity Institute. A lot of his work is about consciousness of humans in the universe, and I think this applies a lot to us as physicians and surgeons. You cannot remove the observer from the data or from the inferences of the data that we are collecting. So the data sphere, right, is corrupted. There's lots of studies and articles that say that when an author is paid by industry or a company, they're up to 200% more likely to talk favorably about a procedure or a device or a drug. The same goes for journals and publications. There's more likely to publish articles that are favorable for the procedures or the technology if there is a financial relationship with the companies. So for this talk, I decided to talk about different things that are kind of new in the world of hernia. And I divided it with the technologies and procedures, technologies being the robotic platform, which might not be very new in terms of this century. Nevertheless, if we think about when the first hernia repairs were described, this was in the 18th century, so they are kind of new technologies. Hybrid mesh suture, the fasciotense, and video-based learning. For the procedures, for the procedures, I am talking a little bit about the robotic E-tap and the SCOLA procedures. So starting with the robotic hernia repair, we have talked about in some other sessions about the PROVE-IT randomized clinical trial. It was trying to demonstrate if there is any difference in laparoscopic procedures versus robotic in terms of pain, recurrence, and quality of life for the patient, length of stay, and cost. It was a 30-day follow-up of a group of patients. There was no difference in the postoperative pain, no difference in the quality of life or length of stay or any of the complications. The operative times was greater in the robotic group as well as the cost. The numbers are really very similar in everything that the authors wanted to actually measure, which was complications and outcomes. Nevertheless, they still have a conclusion that they cannot say that one procedure is better than the other just because the costs are more with the robot. Then we have the follow-up 1 year of the approved clinical trial. So they follow these patients, 95% follow-up of those original ones, the same half and half, more or less laparoscopic versus robotic. And they wanted to measure again the pain, the quality of life with the Hercules score, and recurrence and reoperations. There was no difference in postoperative pain at 1 year. Nevertheless, the robotic patients have a better quality of life as compared to the baseline, but the robotic group had a larger percentage of recurrence of the hernias. All these authors in this study have a conflict of interest with Intuitive, and at the end of the articles, they really cannot say that one is better than the other, and we do need more research. Now talking a little bit about the reinforced tissue matrix mesh. This is a newer type of mesh, and I'm talking specifically about Ovitex tissue reinforcement matrix. It is an ovine tissue with a minimal permanent polymer incorporated within the mesh. The mesh grows into the patient's tissue. The biologic part goes away, and it leaves a small amount of permanent material, which is less in comparison with the regular artificial permanent materials that we use currently. That is the mesh, all the layers of the ovine tissue with the polymer. So TelaBio has partnered with surgeons around the country to do this study. It is the Bravo study. It's a 24-month follow-up with the 1S reinforced tissue matrix. They follow 76 of the 92 originally enrolled patients, ventral hernia repair. The mesh position and the procedure election is up to the surgeon. They found that there is 38% surgical site occurrence. 20% of those were infections, 13% seroma, and 3% of the patients needed a reoperation. The Hercules score, which is the quality of life as reported by the patient, went up from baseline in every patient. And their conclusion is that the mesh, the Ovitex mesh, is a viable option for hernia repair. All these surgeons had a conflict of interest. The conclusion of the surgeons is not that it's compared to any other procedure or to any other material. They're just stating that it's okay to use this mesh. Now we talk about the FascioTens. It's been patented in 2019. It is a device to try to close the gap in larger ventral defects. It applies traction during the operation. There's one of the studies that is stating that this will be a good alternative as opposed to a component separation surgery. There's 21 patients in a 2-year span. Average defect was 17 centimeters. They apply the traction for about 32 minutes. And the average decrease in size is from 9.8 to 7.5 centimeters. All of those hernias were able to be closed primarily, and 19 of them, most of them, were enhanced with an underlay mesh. Their conclusion of this study, it is that it is a large effect. Just that, a large effect. There's no number, no quantification. There's no comparison to anything else that we know, like a component separation or a bridge or any other procedure. This method allows for primary closure. Another fasciotense study is a retrospective review, 50 cases. The gaps were similar, 8 to 44 than the previous study. And the reduction of the defect was from 16 to 5.8 centimeters. Most of the hernia defects could be closed primarily. They had a 12% complication rate and a reoperation of 6%. They conclude, the authors of the study conclude that it's a highly effective, low complication rate and good clinical practicability. There's no numbers, there's no follow-up. We don't know exactly what we are comparing these to. And we talk a little bit about mesh suture. We have seen this in the societies and in the social media, and sometimes in the literature. I've seen some ads in some of our general surgery news. The idea of this is that it distributes the tension in the midline, either during laparotomy closure or during ventral hernia closure. This is what it looks like as compared to the traditional monofilament suture we use for closure. There's several sizes, 0 and number 1. So they did studies in vitro. The mesh had about the same tensile strength of the suture, of the regular suture. There's very resistance to pull through. The linea alba has more elasticity and tensile strength as compared to just the monofilament. And at 8 and 9 days in histological examination of the pigs that underwent these laparotomies, there was complete integration of the mesh into the tissue. They also made studies with tendons in rabbits, and they actually compare these to fiber wire, which is the standard with which orthopedic surgeons repair tendons. So more tendons, when they were applied, the tension of the study ruptured when they were sutured with fiber wire. And the mesh suture was stronger and more tendons were intact after the experiment. They also show you a very pretty slide of the tissue integration of the suture. But there were no human studies, and you can buy this suture to use it in your institution anytime without any human studies on this device. Video-based learning is the last thing I want to talk about technologically wise. And this has been going on way before pandemic. Nevertheless, it became more important when we had our lockdowns and we were trying to figure out ways to learn while separated from one another and not in the classroom or not in the operating theater. This can be real-time video conference as opposed to having a coach or a preceptor present in the operating room. It can be social media videos. Surgeons like to share what they're doing on the daily. And like our colleague said, this is very widespread, and we're implementing some of these procedures without ever reading or knowing anything else about the evidence. There can be also found videos that have been vetted by the surgical societies. So one of these studies that I found was actually published less than 2 weeks ago on the Surgery of Endoscopy, September 5. And it is Zoom-based coaching sessions. There were 8 surgeons, only 6 of these surgeons completed this. And there were hepatobiliary surgeons, endocrine surgeons, different kinds of surgeons. And they did 2 Zoom-based proctoring sessions. They were 6 months apart. And then they answer some questions, the mentors and the mentees, about how good this was for their surgical experience, so to speak. They did not report that there was any improvement in surgical skills per se, but better, there was improvement in their surgical decision-making during the operation. So the conclusion of this study of 6 surgeons that completing is that there's probably educational value into the proctoring remote or video-based learning. There's another one. This was done before pandemic, 2018. And this is from SAGES, sleeve gastrectomy telementoring. It was 17 surgeon trainees. So they were either fellows or residents with 7 surgeons in real time. doing sleep gastrectomy. And it was a quick questionnaire about how satisfied you were with the experience of this mentoring and if there is value or not in the exercise. And both mentors and mentees agrees that there is great value in this video-based in real-time proctoring. So that's what I'm going to talk about, the new technologies. And now I'm just going to briefly talk about the procedures. We start with SCOLA, subcutaneous only endoscopic approach. We see this constantly in the social media platforms, surgeons posting their videos. Is there any evidence that this is good for the patient or not? This is done primarily for very small defects that are concurrent with a diastasis recti in very thin, fit patients with a low BMI. The series are small, 10 to 200 patients. There are surgical size occurrences are most of the complications, 5 to 40% in the series. Most of them are seromas. There's 12% recurrence of the hernias. And again, the follow-up, this is between 30 days to 1 year. And the conclusion of most of these studies is that it's a safe and effective procedure. It has good outcomes, but the surgeon has to select these patients very carefully, low BMI, healthy patients for the most part. So the most important series are one from New York that Flavio is an author in this paper, and one from Brazil. And then lastly, I'm going to talk a little bit about robotic ETEP, enhanced view totally extraperitoneal. So these are new procedures as well. The series are very limited. There's very short-term follow-up. They're comparing to IPOM. Again, it's 2 robotic operations we're comparing here. Is the reveal that Sabrina was talking a little bit about that too. And at the conclusion is that there's really, the authors cannot tell you that there's one better than the other. And at the end of the day, to conclude this, we need more evidence, we need more research to be able to determine if these new procedures are worth it for our patients. Evidence medicine, it's like the beauty is in the eye of the beholder. We need to know when we're trying to sort through these new evidence, new procedures, and the journals that we're trying to read, what types of studies we're looking at, if they're retrospective, longitudinal, the affiliation of the authors, if there's any conflict of interest. For sure, we need more registries, transparency, accountability, and oversight of all this. I'm done.
Okay. All right.
These are my 2 little boys. I think that hernias are gross.
Thank you, Dr. Perez Soto. Any questions? Maybe I'll ask you the question. You've presented a lot of new technologies. Which one of those that you presented have you adopted and why?
So I have adopted the robotic surgery, and it's because like the evidence that we have seen shows that there's really not a lot of difference between laparoscopic techniques and robotic, just the cost. But again, I am not paying for that. And for me as a surgeon, is more efficient. And I have found anecdotally through my patients and my practice that the patients do better with the robot than laparoscopic.
So let's keep this in mind for the discussion later on. Go ahead.
Well, it's along those lines. So I'm Peter Chang, I'm from Austin, Texas. We have the highest penetration of robotic surgery for general surgery. And the data for robotic, of course, is not the greatest. Is that because our study designs are not capable of seeing the differences? I mean, the randomized controlled trial for open versus robotic prostate didn't show a benefit to robotic. That's crazy. I'm not having open prostate surgery. There's just no way it's not a better operation. But at the same time, everybody thought the world was flat at one point. So is it that we're not measuring the right things? Do we, is there really no benefit? How do we, put this in our practice? Does that mean that every robotic case has to be on a study? And so how do you guys handle these issues?
I can start a little bit of,
Yeah.
that's kind of what I brought up is, can statistics actually answer that question and should we expect it to? And I think that's kind of the question of our day and age when we maybe rely too heavy on statistics. Again, the studies we're doing, yes, like the rival trial I showed, it was a prospective randomized controlled trial, but even if the study design was appropriate, it was only 110 patients. Are we really going to answer the difference between laparoscopic and robotic? And are they asking the right questions? They did ask about surgeon ergonomics, but we don't quite know where those surgeons were on their learning curve, and operative time was longer. But again, there's just so many factors to account for, and that's where we need these big data registries with thousands and thousands of patients to potentially see the difference. But I'd still argue that I'm not sure statistics can answer the question, because statistics with gallbladders, we all adopted laparoscopy despite statistics showing it was an awful idea to proceed with laparoscopic gallbladders, and look at where we are now.
Same thing with appendectomy. They did a paper that showed lab happening better than open
To the button to the right. Yeah.
That one, yeah. So, is the trial design any good? Short answer, no. It's very simple. If you want to go and look at the highest quality funding bodies that exist around the world, and I'll use NIHR as one example, CIHR could be another, the Aussies could be the same. There is no randomized controlled trial funded by those bodies of A versus B, a simple one-to-one randomization that has a sample size of less than 500. Why? Because the effect size that you need for sample sizes lower than that are so large that neither the patient nor the surgeon could reasonably be expected to have equipoise. Now, there's a load of data from the psychology literature about where the tipping point is in terms of relative risk reduction if you're looking at trial design as to where you can and can't see that difference. And it's estimated to be about 25%. But we're seeing a lot of these trials, with randomization of 36 versus 38 or of 50 or 60 of this against one another. I mean, it's just frankly nonsense. Most of them need to go in the bin. And this is what I was saying before to Ali about the concept that most of these trials should never have seen the light of day. And I have to say, I think we need to get away from this garbage idea of doing poor quality RCTs and dumping them in something like annals of surgery or JAMA surgery. We need to ask better questions, bigger, more important questions, ones that are central to patients, and we need to design the trials properly. Just going to say what Doug Altman said before. We need to do less research. We need to do better research.
Just one quick comment that the rival trial was a pilot study, and it didn't have a sample size. It didn't follow a lot of the criteria of the clinical trial.
Yeah, and again, what we mean by pilot trials and what we mean by feasibility studies, again, is mired in controversy. And again, if you look at what the definitions are for many of the funders, it didn't meet those either. And again, those things are open access. You can access them off any of the funders' websites. Just read the instructions, please. It's not that difficult.
Yeah, I think that, I'm a big believer in math or maths, if you like it. But, if you ask the question well, you will get a statistical difference. And one of the big problems too is we lean on like the American Hernia Society Quality Collaborative, been around for 10 years. And when this thing started, I mean, I was president when I said, we need to fund this, we need to do this, Mike. And he's done a yeoman's job putting it together. The problem is we have surgeons grading themselves in this, and also patient participation. We have patients, everybody comes to my office, 100% have seen these mesh trials and these class action lawsuits, and they're afraid of mesh. And 48% of people who come in say mesh equals complications in the prospective study we did, but then only 9% of the patients with the AHS QC or Core Health now will actually return their quality of life statements. So it makes it extremely difficult to actually improve patients' quality of life when they're stomping their feet in my office to begin with, and then they won't return their quality of life statements to help us take better care of the next generation. All right, so Flavio, you ready? So Flavio is going to talk about, can we equate experience with evidence? Everyone knows Flavio from Brazil, from Rio, moved to the United States 7 years ago now, 7 years ago, took New York by storm and now has moved over and into another zip code in New York, taken over NYU, and will be president a year from now. And We look forward to your comments.
Thanks so much, Todd. It's a really honor to be here between those giants in hernia surgery. And it's not an easy topic. I think none of our topics today are easy I put myself as Sabrina as a regular surgeon. I just work here. I just do my cases. But I like a little bit of challenge. And I think this talk challenged me to think about it, this subject. And I'll share with you the next 10 minutes, my thoughts on it. And I'm really happy to answer any questions. And those are my disclosures. Clearly, I'm not talking about hernia surgery itself, but they'll be there for you to judge. So when I got the topic, experience and evidence are the main words on this title. So I went to Oxford Dictionary, and what it means by experience, and that's the definition of experience. So, okay, very simple, very straightforward. And what's the definition of evidence is the available body of facts or information indicating whatever belief or proposition is true or valid. So to get evidence from me needs observation, and I need information, and we get information and observation for experience. So I think that they are really, really linked, and I want to build a little bit on this. Sabrina showed the levels of evidence, and I don't know how many ways people can be creative to create different color rainbow pyramids, but everyone finds a different way to build this. It's so nice. It looks so good. So I couldn't get enough of them. So, and we discussed a little bit about those levels of evidence. And that's what we mentioned earlier, brought on the 90s. That's the Oxford Center of Evidence-Based Medicine, the levels of evidence from 1A to 5 and grade of recommendations. And I think when we talk about evidence, what we're looking really after are those grade A recommendations at level 1A and B of evidence. And that's why the best evidence that I was taught to search for. But I think experience lays right here, but it still has a space on publication. I think those case series, individual report, those are reports of experience of surgeons or academic physicians that are trying to spread their own clinical experience on a certain topic. So let's go to a practical scenario. So 7 a.m., you're late for OR, you need to round, and you see this female that was admitted last night, abdominal pain, gallstones. She denied surgery before. Now she come with pain, some mild elevated white blood count, and the diagnosis is clear. It's a biliary pancreatitis, everything's fine. So you say, okay, next case. And the intern, always the intern, raise their hand and say, are we going to prescribe some antibiotics? And the chief resident says, sure, let's do some marrow. And the intern asks, and the med students say, why marrow? And you start rolling your eyes, and the intern say, oh, yes, because I learned in my rotation CQ that every sick patient needs to have some kind of real tough antibiotics, and marrow is a very good one. And then the PGY2 said, okay, the patient is not infected. I just read some of this publication. We don't need to. And now at this time, you lose your mind. I say, come on, I need to go to OR. I need to move forward. But what is the closest truth? It is a good idea to prescribe antibiotics, or is, as some trials show, that it's completely useless to prescribe antibiotics. And just a quick example of those clinical decisions that we need to take daily on our practice, that we need to base our decision on something, either experience, evidence, or both. I love this publication. This was published many years ago in a British Medical Journal. Does parachutes prevent death on a gravitational challenge? There's no randomized control trial show that. And what do we know about it? We know that we use parachute to prevent death when we challenge gravity. Parachute use can have adverse events. It's not risk-free to use a parachute. And not everyone that challenges gravity really dies. So should we really study the effect of parachute using when you jump out of a plane? So there's no randomized control trials. The use is purely observational. It's just based on experience of people, and people do insist, and the intervention needs to be validated by randomized control trial.
for sure just a joke, but it's real. Nothing that is written on this slide is a lie, but still we don't have, as we just discussing, the prostatectomy or the cholecystectomy. There was never really a good trial about it. So when we think about a randomized controlled trial, we think that the main setup of this trial is really summarized here. But let's pay attention what the name says. The name says randomized control trial. And on my being very naive, I thought that the control part of it was really to have a control group, maybe because English is not my native tongue. But really, when you do control a trial, you really control every step of it. Okay? We don't control every step of our life. I mean, I've been married for 22 years. Somebody controls my life, but that's not me, clearly. But we can't control our patient's life all the time. There's so many variables in our on our hernia repair practice that becomes from patients' demographics, so many different alternatives, so many different technologies to imply. I think it's humanly impossible to control every piece of those variables. And we want to reduce bias, so we try to increase numbers of variables, but yes, we can control, we can do a better job controlling variation, but we're going to really increase other problems when we increase the number of variables. So I imagine that a randomized control trial may be very important on if we control or if we compare intervention that have a really different impact on the outcomes. For example, should we use mesh on a peristomal hernia repair, and then have very strong trials that really give that answer that yes, the difference is so absurd that probably is a good answer for a small randomized control trial. Possibly can help us somehow when we have a substantial impact of intervention. We still have some variables, and the classic example would be, should we use mesh or non-mesh to repair incisional hernias? Some variables, which mesh, where should I position the mesh, should I fixate the mesh or not, what's the size of the defect, but the impact is important. So probably can help us to answer the question. But sometimes it's absolutely impossible to use a randomized control trial to answer what is the best fixation? Should I use the TAPP or TEP? Should I use the mesh A, B, or C? This is absolutely impossible that randomized control trial will give us the answer that we need. And that slide Todd nicely and kindly shared with me, and something that I completely didn't know about until last year when I heard him talking about is the fragility index. And how should we really deeply analyze a randomized control trial and see what could be different and if a few patients change the outcome. So a quick example of this is the trial that I just mentioned, that we probably is one of the most cited trials on any incisional hernia paper, as we should use mesh from Dr. Yeko groups and many years ago. So the fragility index of that paper is 7. What that means? That means if 7 patients out of those 2 groups, they have different outcomes, the paper would not have significant statistic results. Okay, 7 is maybe a high number, but if you pay attention to details, in a 10-year follow-up, out of the 200 patients that were randomized, they lost 74 patients on follow-up. Now I'm telling you, if 7 out of those 74 patients have a different outcome, probably we didn't have a statistical results for this super-cited paper. Another paper that, I mean, this was published 2004, if I'm not wrong, and my senior partner used to walk off this paper on his bag and just showing everyone why we should not do laparoscopy in hernia repair. It's published in New England Journal of Medicine. And Fitzgibbons did a nice work trying to study the problem and show us some results. So they show more than double of recurrence when you do a laparoscopic hernia repair and when you compare with an open Liechtenstein repair, more complication, but it does show less pain and sooner return to activity. So my partner would walk and shove in my face that we should stop doing laparoscopy in hernia repairs. But if you really look into the paper, come on, who thinks that 5% Liechtenstein hernia recurrence is a good result? That
challenge us to really analyze how good those surgeons are doing Liechtenstein inguinal hernia repair. If you dig it a little bit deeper, if you see it's written right there, if those laparoscopic surgeons have more than 250 surgeries under their belt, there's no difference on the recurrence. So experience matters. If you just read the conclusion of the paper, maybe you have a different opinion than if you compare really deeper on the paper. And that's what Todd just mentioned on our Sabrina's talk. We need to understand the difference between efficacy and effectiveness. So it sounds pretty much the same, but they are not the same. Efficacy should be determined if the outcome occurs in ideal conditions. Do we always operate in ideal conditions? I don't think so. So effectiveness should be measured about the degree of beneficial effect in real world settings. There's so many limitations for randomized controlled trials. I'm running out of time, and I don't think that we have time to go over all this, but one of the solutions might be, as is written there, do different study designs, not only randomized controlled trials, and something that we discussed here earlier today is also validity or external validity of the randomized controlled trials to see, really understand to whom those trials or those results should be replicated or will be replicated. Pragmatic trials is something that we also heard here before, is something that we need to consider if you want to validate or bring to the real world the results of a clinical trial. I think that really at the end of the day, we want to join and merge evidence with the clinical experience, and that probably will give us the best care. Don't forget to put the patient's expectations and wishes into this equation. So I think we should go from evidence-based medicine standardization to some clinical scenarios and visualization. It's our duty as a physician to imply the best job for our patients. Nobody wants to be dumb. Maybe what's the first name of George W. Bush is not Edmund. The smart person learns from his or her own mistakes, but I think the wise learns from others' mistakes. I think we should at least be smart, but if possibly, we should all be wise and try to use other experience. So back to clinical scenarios, you can study as much as you want, but sometimes comes to a patient that you can't really can't find the answer of this patient. Oh, I think a Liechtenstein has been proven okay for this patient. And then we should need to expert opinion and experience opinions to see what will be the best results and what I call the good care or the wonder. So I don't know how many of you know what Sumerian. Sumerian is the first language ever written 5,000 years ago. And I think that what really create the big civilizations of our race, of our species, actually, is when we start to be a civilization and when we start writing down. We exist as Homo sapiens for thousands and thousands of years. We didn't go anywhere until we started writing down because we were able to pass information to a different generation. Otherwise, everything that you learn in your life, you cannot speak and tell your son or a family, but now you can write. So let's write. I don't care which grade of recommendation you write into, but let's write. Let's put out there your experience that we might learn, others might learn from your experience. And I want to close up with this Theodore Roosevelt quote that I really, really like, and it's kind of long, but it's not the critic who counts, not the man who points out how strong the strong man stumbles. The credit belongs to the man who's actually into the arena. If he fails, at least he fails while daring greatly. So let's all be vulnerable. Let's all come to arena. Let's all publish and write about the experience. So that's the only way that we can try to be wise together. So come to arena and share your experience with everyone else. That's the only way that we can move forward. Thank you so much.
Any questions to Flavio? Very nicely done. Just for the sake of time, we're going to move into the last talk. Can we equate eminence with evidence? Dr. Shirin Tawfiq from the Beverly Hills Hernia Center. She's very well known to this society and to the world of hernia. Dr. Tawfiq.
Like it. Wasn't my choice, but I like it. All right, remind me not to ever accept following Flavio for a debate. All right, can we equate eminence or evidence? So I also went to the dictionary. I used the Merriam-Webster, not the Oxford. Here's the definition of eminence. Those of you who follow the Pope know the cardinals. They're called His Eminence, the High Eminence. So it's really kind of this idea that there's a grander person or grander expert. Those of you from my generation or before, there's a lot of trust me on the doctor comments on TV, on t-shirts. It was kind of a thing where medicine was really heavily relying on clinical experience, advice, opinions. You remember Halstead, we got Bassini, Nehus. These are all prominent names. We followed them and what they did. I would argue that modern medicine is moving a little bit away from that. We really have databases and registries and patient-related, patient-reported outcomes, clinical trials. We have Neil Smart, who's reviewer number 2 for everything. And we really don't have articles anymore or journals anymore that have like case reports available or how I do it articles. Those are kind of gone from most prominent journals. There are different types of medical kind of decision-making. Evidence-based is kind of the common one. That's based on randomized clinical trials. I like this eminence-based. It's a radiance of the kind of the gray hair, the halo effect. Go down a little bit. There's elegance-based. You know, it's how nicely your tie is, how beautiful the office is. And if you got like this beautifully slicked back hair, then, and you tell the patient what to do, then they're more likely to follow that. That's based on the Teflometer and adhesion score. Going down, there's the confidence-based medicine, which is based on bravado. There's a sweat test and the unit of measurement is no sweat. And in this article, this only applies to surgeons. So does eminence equal evidence? I'll give you a couple of examples. Dr. Gilbert, one of my favorite people in the society, very, very talented, former past president of the American Hernia Society, founding member. He came up with, based on his experience, the Perline hernia system mesh, and had excellent results in his patients. In fact, in his whole practice, they were using the PHS mesh almost exclusively. Excellent results, no chronic pain. This was a sutureless, basically tension-free repair. Sounded great. Rutko and Robbins came up with the mesh plug. There were different iterations prior to that. That was modified by Milliken. There were some problems with the initial rollout. Milliken, over 1,000 patients. People were being sent to him to learn how to do this better than the original description. He showed short recovery, smaller incisions, you know, good follow-up. Patients did really well, skilled surgeon. And yet, we're removing these things now. What's going on? When we looked at why we removed mesh, half of the time we were removing it from meshomas, and most of these were from the PHS mesh and the mesh plug. So the issue with surgery is there's just way too many variables. Surgical techniques are not the same among surgeons. I watched, were you guys at the fireside chat today? A lot of the techniques that I would not have done, or not kind of how I would have done it. And yet these are experts out there that do this on a daily basis, potentially probably with good outcomes. Dr. Gilbert, Dr. Milliken, all had excellent outcomes. Why is that not translatable to the average surgeon? But I'll tell you, there's some surgeons that have the hands of God. When I was a resident, is Sunil here? He gave a great talk and he referred to Dr. Busatil. I was a chief resident when he was our fellow in liver transplant. And he operated on livers that every single institution rejected. And these patients did amazingly well. But we know we called in the hands of God. So I think we should be using Eminence to help gather evidence. For example, let's talk about laparoscopic surgery for ventral hernias. You may not know this, but pretty much that was a technique that predated laparoscopic inguinal hernia repairs. And afterwards, we're like, okay, these are excellent surgeons, Henneford, Adrian Park, Dr. Ramshaw, Guy Veller, superb laparoscopic surgeons for their time. And let's see how it goes. Let's look at the outcomes. And it was a collaborative study. They were very honest with their data. They presented the American Surgical Association. You can't get more eminent than that for a society. And they had complications, reasonable, but they were very honest about showing these complications. And that's where Eminence is there to show, to then get evidence. Let's look at MIS tissue repair. So we published our robotic iliopubic tract repair. I'll talk about it more tomorrow. But Dr. Nihus was actually the original person, eminent surgeon, that came up with this. And I said, okay, if he can do a tissue repair posteriorly open, then I can do it robotically. Why not? I understand anatomy. Let's do it. I went to my IRB. This technique has never been done before. Can I just do it? They're like, well, I mean, you're technically not reinventing the technique at the tissue level. Yeah, you don't need an IRB. It's not considered experimental. I didn't feel comfortable with that. I felt like I had to tell my patients. So we went through the formal IRB process and we enrolled our patients and we followed the data. And you know what we found? It's a good technique, not for most patients. There are problems, there are nerves that can be injured. Maybe for small indirect hernias or really small direct hernias, low risk patients, non-obese, it's a good technique, not for everyone. And let's talk about robotics. So the application of robotics for hernia repair, as many have mentioned today, took off really without clear evidence or any studies on its efficacy and outcomes. We knew it was safe as a robotic robotic surgery was safe, but the efficacy and outcomes were not there. And most of the publications we actually have about hernias is within the past 5 years. And as you know, only a handful of randomized clinical trials, mostly observational studies. This is a great paper, not written by robotic surgeons, very objectively looked at the data. And they basically showed the blue is robotics versus lap, and the red is robotics versus open. There's very low grade evidence and no clear superiority of robotics for hernia repairs. I was recently asked to give a talk on the indications for robotic surgery for primary ventral hernia repairs. So we know there's no defined algorithm. There's no robotic algorithm validated for indications. I couldn't bring up a paper or a publication or a guideline that said this is how you should do, what you should do robotically, what you shouldn't. And to be honest, we're still in our learning curve. We have not reached a steady state of robotic surgery for ventral hernias. So, okay, how am I supposed to give this talk? Where's the evidence to support a talk on indications? So that I said, okay, I can't look at literature. There's not much there. So let's look at real world data. What are surgeons actually doing? And the ACHQC showed that really there's no difference in how robotics and laparoscopic surgery are applied in terms of indications. So why are we doing this robotically if it's the same patient population? Look at the IHC. They did a study. What cases do you guys do? Number 2 and number 3 are robotic cases. There's this other study arguing in favor of robotic IPOM. IPOM was commonly performed and the recurrence was similar between robotic and non-robotic. But if it's similar, then why are we doing it robotically if everything else is the same? NSQIP more real world data. Let's look at the 10-year data. Really, there hasn't been much of a shift since robotics of open cases being done more minimally invasively. So, okay, that didn't work out. Let's look at the experts. Really, those are the eminence, right? We kind of use that term loosely sometimes, but let's look at eminence to seek guidance. Here's this paper looking at kind of how they do laparoscopic versus robotic retromuscular repairs. And if you look at it, the patients are completely different. With robotics, they were doing it retromuscular. When they were doing it lap, it was an IPOM. For robotics, they were doing TARS on these patients. But when they were doing lap, they weren't doing any components releases. When they were doing robotic patients, they're closing the defect. With laparoscopy, they only close the defect about half the time. And they said, you know what? Robotics is just a better repair. You can argue that retrorectus, closing the defect, is a better repair, but they're not really comparing the two perfectly together. So this is the other analogy I use, and I'm going to continue it today. Kamal knows this analogy, but don't tell him the secret. So I said robotics is like an SUV, and I'll explain to you why. So these are the 4 cars I've owned in the past. I'm really into cars. I like sports cars too, but I've owned a fair number of SUVs, and they're really amazing. But you're going to say, Tofi, why do you have it? Why do you even buy an SUV? So you don't go camping. You're not hauling a boat. You're not off-roading. You have no kids. Why do you need an SUV? You live in Los Angeles. But I'm telling you, it's very comfortable. It's roomy. My mom's knees are bad, so it's great for her. I like riding high in LA traffic. And in Beverly Hills, pretty much everyone owns an SUV, whether you need it or not. So that's why. Those are the reasons. I kind of ignore the fact that it costs a lot of money. It uses up a lot of gas. It's horrible to park. It takes up way too much room. And I literally do not need an SUV. So this is eminence versus evidence, right? So robotics is kind of like the SUV. A lot of surgeons like it. Objectively, it may not be indicated for any operations. In some cases, open or laparoscopic is just as good. More technology is not necessarily always better. And so I would have to say that we just need to be honest about the data, because whether you like it or not, the data needs to supersede everything else. And what to do if there's no evidence yet? I think the eminence can bring the evidence. And I want to just say that it's a responsibility of eminent surgeons to help gather that evidence. And even though we're way down on that bottom, no matter how many colors you put, it's always on the bottom, is the evidence by the expert. But expert opinion is not a bad starting point, and it can push that evidence up the pyramid. And I just want to give kudos to our past president of the Hernia Society, Dr. Henneford, because he has been one of those eminent surgeons who has brought in evidence, highly cited papers, and constantly improving and not picking just one thing to do. So eminence begets evidence. Eminence should be respected insofar as it's compatible with evidence, but it's not acceptable to just say, trust me, or I say so. And so for those of you who are wondering, this is my car currently, but I have my eye on this one. So thank you very much.
Oh, wait a second. We got like a minute and a half, 2
Yes.
minutes. So stay up here. Stay up here. Questions for Sharon?
Thank you very much. I really enjoyed the talks. Obviously, we have a saying, this is a responsible body of surgical opinion. And that's what we use when we write reports. So I hear that database entry, real-time entry, not only should it be compulsory, but it's better than randomized controlled trial evidence. Is that reasonable?
I think it depends upon how the databases are done and who's doing the data entry. Because if you've got the same surgeon who's done the operation and has the complication, you know, it's the, oh, no, it's not an anastomotic leak. It's just a collection of gas and fluid right next to the anastomosis that's resting there. You know, and it's just, and this is where it gets problematic. It's who does the follow-up, who assesses the complication, how good are they at assessing the wound complications. If I were to express a preference, I'd say dedicated prospective observational cohort studies are better than registries, and you have to have the infrastructure. Now, different countries do it differently and the funding matters, but they can be very powerful.
So Sharon, how do you develop eminence in your profession?
I would say that. Is this on? That's a hard question. I think eminence is bestowed upon you. People that claim to be like the leader or I think it should be a label that's bestowed upon you. So there are certain people that you respect them. You know, for anyone who's been sued, you understand there's expert opinion, right? How many of those people are truly experts? They're just kind of fit the bill for whatever argument you want to make. Those are not truly eminent surgeons, in my opinion. You know, it's based on how honest you are about advancement and innovation, being open to it, respecting data and not kind of slamming it because you don't believe it. It's very humbling, is that part of that ego thing too. I think the more eminent you are, I would prefer that eminent surgeons kind of be, you know, less egotistical, and the best really are. They're very open to change and innovation.
So if I may, I'm going to conclude here with one statement, and I want to see if you all agree with me. I think the message that we can take from this panel is that the evidence so far in hernia surgery is poor, that we need to continue generating the evidence in order to obtain best practice. In the meantime, we can continue to rely on experience and eminence and do what Todd has done, which is to generate the evidence from eminence and experience. Any other message that we should deliver from this panel? Todd, do you agree?
I will repeat, come to the arena, publish, write down, no matter where, be there, be out there, so others can learn from your experience. And then we build together evidence.
Can I just say, you know, Kamal mentioned that it was a pilot study and Agitus, and therefore, you know, it's faced a lot of criticism, but there's a lot of fellows and residents here. It's important to publish, and you learn, and your publications will get better as you get older. You have more data and you're wiser. But when I was a trainee, and even now, pilot and preliminary are my favorite words, because I know I will get it published, but it's important to show what the early findings are. I love those words. And I think it's good that we carry on publishing. And it's good that we learn from our publications. I mean, with Todd's experience and Shirin's experience, you get even more data. Then you can compare your pilot and preliminary to their experience. So I still think we should continue to publish and don't detract from it.
I think one of the things that Sharon said also is super important. My first America's Hernia Society meeting years ago, I was in the back of the room and someone stood up and truly said, we did 400 of these cases. We had one wound complication, you know, one minor DVT, no recurrences, and everybody's lovely. And I said, well, we should stop everything we're doing from now on forever and do that. Because we will never beat that. We'll never be better than that. I think the most important thing that we've done as hernia surgeons is push our ego to the side and allow ourselves to be wrong.
Yeah.
And if you look at the number of complications in the press in the world, they're going up for abdominal reconstruction. Recurrences have gone up for abdominal reconstruction, not because we're bad surgeons, but because we're allowing ourselves to publish the truth. And if you don't give yourself a report card, you will never improve. What drives me and what drove you as kids, because you were pleasers for your parents, pleasers for yourself, driving yourself is you wanted to drive for a good report card. And it's driven our egos as well. But, you know, we have to, you know what 3M does? 3M, they actually look at their failures, and their engineers get together with their failures and they talk about their failures and what they can do with their failures, kind of like what we do here. And they celebrate their failures to learn from each other.
So I would like to thank all the panelists for absolutely outstanding presentations and all the attendees for staying till the end. Thank you. As always, I had no idea.